and to deliver a lecture on nail disorders, a topic which is extremely close to my heart. I bring greetings from Nail Society of India. It's a society with more than 500 dermatologist members and few plastic surgeons and pathologists. And I have no conflict of interest and I have no financial disclosures to make. So the scope of this communication and the learning objectives will be why to examine nails, because nail is an appendage which is really a neglected one, especially in the pediatric population. But it can give a plethora of information actually once you know it. So I'll talk about why to examine nails, prerequisite for nail examination and anatomy of nail unit. For the pediatricians to be able to identify what are the physiological nail lesions, especially in children, because their majority of them, physiological changes occur in the pediatric age group, to identify common nail disorders in children and classify according to etiology. And at the end of the lecture, you should be able to diagnose, confirm the diagnosis and treat common nail disorders that are encountered in this age group. And very, very important and most important, I would say, you should be able to know when to refer to a dermatologist, because, referring is an art, a forgotten art, I believe. So,
and sorry to interrupt you, Dr. Amol has joined. I'll just request him to say a few words. Dr. Amol, good morning. Please say a few words and then we'll carry on with the session. Please unmute.
Thank you, Dr. Ajay sir. It is very nice initiative, and from Central IIP, specifically this pediatric dermatology course, Dr. Alok Bhandari sir, Archana ma'am sir, then all the staff who are always to learn something different in pediatric dermatology for 6 months. And then I got to know the importance of this initiative. Dr. Ajay sir has taken this initiative, Dr. Alok sir and whole Delhi IIP is contributing a lot for this thing. And so we are almost 45,000 pediatric out of. Thank you for inviting me, Dr. Ajay Kumar sir, and I wish all the delegates a happy learning.
Thank you, Dr. Amol, for your kind words. I request Dr. Archana ma'am to please carry on with the session.
Yeah, I must say that it's a great initiative to learn from each other. So why examine nail and how? So nail may represent a window to internal disease. They may feature the first and the only symptom of an asymptomatic disease. Sometimes you see that the manifestation is only on the nails. And in a pediatric age group especially, they may be a considerable source of anxiety for the parents. And the best part of the nail disorders is that all 20 nails are, accessible for direct clinical examination. You don't have to undress the patient or anything like that. And for each patient, we have the privilege to examine 20 nails, and they should be examined always in the good light. Though fingernails definitely provide more accurate information about any disease than the toenails, because toenails are more likely to get secondary changes because of the trauma which they are more likely to undergo as compared to fingernails. And these days, and for the diagnosis, nail unit biopsy is seldom required, in contrast to the many skin disorders where you must have seen after a series of lectures that, we often advocate skin biopsy, but in nail, we also have an additional tool to examine, which is a dermatoscope, dermoscopy, which is an interface between the clinical examination and the histopathology. And it's a non-invasive tool, and it's really picking up because it confirms the diagnosis. It's an office procedure, and it confirms the diagnosis there and then without an invasive investigations. So a little bit about the embryology of nail. unit. It gets the nail apparatus begin to form at 8th week of gestation, and the nail plate is completed by 5th month of gestation. You know, looking at the nail, you can see that the child is premature, a neonate, or if attained fetal maturity, or post-term neonate. I'll show you the pictures. So, you know, you see this is a term neonate where the nail plate is reaching up to the tip of the pulp of the finger. While it is, this is definitely preterm because the nail plate is yet to reach the tip of the pulp. And this is definitely post-term because you can see about 1 millimeter of growth beyond the pulp of the finger. So looking at the nails, you can determine the fetal maturity. And these are because we'll talk about different parts of the nail when during the description. So just a very brief that this is lateral nail fold. So for each nail apparatus or each nail unit, you have two lateral nail folds, medial and lateral. This is proximal nail fold, and underlying the proximal nail fold is a matrix, nail matrix, from where the nail plate forms. And this is a sacrosanct area. You know, most of the manifestations on the nail plate are because of the pathology in the nail matrix. And nail matrix forms the nail plate, which is the hard keratinized structure under which lies on the nail bed, which is very vascular, and that's why it appears pink in healthy nail. And then most important part is cuticle. It is the visible, this is a transparent layer which binds the proximal nail fold firmly onto the nail plate so that there is no potential space for invasion of microorganisms, right? And distally, once the nail plate is free, where the distal end of the is free, that is known as hyponychium, where the dermatoglyphics start beginning to form again. And the distally, the nail plate is very, very firmly attached to the that is known as onychodermal band. So again, it is again a barrier for invasion of the microorganisms. So we can classify nail changes according to whether they are physiological, infections, tumors, nutritional deficiency. Certain manifestations are part of the inherited and congenital syndrome, inherited, and then in different skin diseases, nail can be associated. And in children, very important is trauma. So pseudo-ingrown toenail, you must have seen like there is a blocked nasolacrimal duct. Pseudo-ingrown toenail are also pretty common. They are, as compared to the adult, it's not painful. They're seen in about 2% cases. There is no excessive crying or touching. It is just that, you know, the nail fold is short and beginning to, you know, cover the, it is being formed. So it covers the nail plate, and it corrects spontaneously in a year or so and doesn't require any intervention. So it's non-tender. Physiological koilonychia is actually very common, and these are the nails of a sister in my hospital who got her two daughters, and she thought that it is because of the anemia, but these are in very thin and everted nail plate, more so on the toenails. And the nail curvature is reversed in koilonychia. You know, it's spoon shaped, but they tend to disappear spontaneously in first 10 years of life as the nail plate thickens, right? So this can be physiological also. Koilonychia is not always associated with iron deficiency. What else is physiological depends on the age. Like in newborn, there can be Bowes line, which are very important. Absence of lunula as the matrix, because lunula is the visible part of the matrix. So as the nail grows, it becomes more visible. It's a small whitish semilunar moon-shaped structure on the proximal part of the nail fold. And there can be slight transient brown pigmentation of the proximal nail fold, and majority more so in skin of colors like us Indians. And there can be punctate leukonychia because of the trauma to the matrix. Onychoschisia is splitting of nail plate. So that can also occur. Now, Bowes lines are the lines when you see in adults also, whenever there is a systemic disease or something like that happening, or any kind of stress, the environmental stress, physical stress, mental stress, the Bowes line start to form because they represent the stressful period. So in neonate or in newborn, those lines are often present, and they tell us that the child has been intrauterine stress of some kind. In 1 to 3 years of age, punctate leukonychia. Leukonychia means the white spots they form, and they are definitely not because of the calcium deficiency, because calcium is not an integral or important component of the nail plate. It's just protein. As compared to the bony and the skeletal structure, I've added a slide later on. Calcium is not important to nail for anything, for surface changes or for the brittleness. 3 to 5 years, you can see chevron nails when there are inverted V-shaped, furrow in the center, which again resolves spontaneously. And 5 to 7 year nail biting, lamellar dystrophy, koilonychia, and malalignment of the toes is again their physiological changes. So as the child grows, these get corrected. As I told you, that nail involvement can also be part of the inherited and congenital nail disorders, which can be limited to only nail, or can involve nail and skin, or can involve nail, skin, and other systemic organs. So if they are restricted to nails, like this is a case of congenital anonychia and partial anonychia. So on the toenail, you see a small rudimentary nail, which is the nail plate is not fully developed. And you can see the proximal nail fold is also so narrow, right? And there you see the sockets, but the germinal matrix has been absent, and so there is no nail plate formation. So this is not unheard of, or this is not unknown, and but we can counsel the patient, because a nail has to be implanted otherwise. But these days, medical tattooing can give exactly the same appearance as a normal nail. But this, if you want the normal nail to grow, then you have to implant the nail matrix, but then you have to sacrifice it from some other nail. Pachyonychia congenita, it's a rare disorder which is autosomal dominant inheritance, and because of the gene mutation in K6, 16, 17, which are manifested on the nail bed. So it is not, as you can see, these heaped up or wedge-shaped nail bed, but the nail plate is normal. You can see the nail plate is normal. It gets lifted because of the hyperkeratosis of the nail bed, because the gene mutation is happening only in the nail bed. And there can be associations like palmoplantar keratoderma, follicular hyperkeratosis, and oral leukokeratosis. It's a common entity. And 50% of the patient will manifest in the first year of life. Otherwise, it's more common we see around 10 years of age. And these patients need to be referred to us, because sometimes this becomes really painful, and then we have to give intermittent. Since it's a disorder of keratinization, we have to give retinoids, and acid retin is the one which works to some extent, but we cannot give it for a very prolonged time because of its effect on the skeletal system in the form of disseminated hyperostosis, interstitial hyperostosis. So it's better that we give intermittent acid retin. And the other component of acid retin treatment is that since it stays in the blood for a very long time, around 3 to 6 months. So as it is, you don't require it for a very long time. Nail in epidermolysis bullosa, we know it's a disorder, mechanobullous disorder. And naturally, this is doesn't occur in isolation, but always in association with the skin changes, and can be managed, again, to be referred. Nail patella syndrome is one entity where there is multiple system involvement. But the fingernail changes occur in about 98%. So, looking at the wedge-shaped or V-shaped lunula, as you see in this picture, can give you a clue to the underlying nail patella syndrome. Then there is renal involvement, missile creases on the distal interphalangeal joint, and aplastic patella is seen in 90% of the cases. So this requires multidisciplinary approach, but nail findings can assist in the diagnosis. Coming to infections, periangle warts are very common, and more so in pediatric age group. caused by HPV 1 to 4. They tend to resolve spontaneously, but we don't wait because they get disseminated, or with the help of the child bites the nail and may auto inoculate at some other place. So they are more commonly seen on the proximal nail fold or the lateral nail fold. If they are in the distal part, they lift the nail plate and may cause destruction of the nail plate. So they can be extensive on the dorsa of the hands and feet. Just because of the auto inoculation, they become widespread. So this, you can see that this is a picture where there is a subungual wart, and it has led to almost complete destruction of the nail plate. But when they are on the lateral nail fold, they are oblique in structure and unlikely to cause destruction of the nail plate. The diagnosis is mainly clinical, but since we have dermatoscope, we can look under the polarizing dermoscopy. We can see these thrombosed blood vessels. They are very characteristic. But in pediatric age group, there are very few differential diagnoses, in contrast to the older age group, where we have to rule out squamous cell carcinoma or Bowen's disease or other benign and malignant tumors. So why, because they resolve spontaneously, then why need to we treat them? Because they can be source of spread at other body sites. There is no medical treatment available. We have destructive modalities, physical destructive modalities like chemical cautery can be done with pairing, or radio frequency ablation, or laser, or cryosurgery, but the recurrence rate is very high, and it is very difficult to know, what is the exact extent of the lesion. And that's why dermoscopy becomes very important, because for how long the wart is extending under the nail plate. And there are a lot of treatment challenges with the treatment of warts, because the recurrence is the rule, especially with radio frequency, because you can't go underneath the nail plate, and destruction of the nail plate happens, leading to deformity. And if we give systemic therapy, like it's not done for the nail involvement alone, and it's not targeted, the side effects are too many. So you can see that this child had a nail, had a wart in the proximal area, and he also has periungual warts in the lateral nail fold and the hyponychium. And because they keep biting, so he's developed a varicose lesion in the oral cavity. So how they disseminate if you don't treat them? We don't watch for 5 years to treat them. So how do I manage? Actually, these patients need to be referred to a dermatologist. I use intralesional bleomycin if it is below, more patient is more than 5 years of age. It's an anti-tumor agent with antibacterial and antiviral properties. And it's a very painful injection. So counsel the patient, talk to the child during injection. I call it vocal local or tochisthesia. I use a very fine 30 gauge insulin syringe with permanently attached needle, so that there is no spurting of when you are injecting it. We have to to decrease the intensity of pain. You can bring the this injection of bleomycin at the room temperature, and you have to know how to inject it. So mostly I'll say refer. And it's not that children do not cooperate, because some school going children get bullied in the school. So they are very, focused, or they're keen on getting treatment. So this was a girl, 6-year-old, with multiple warts, involvement of multiple fingers. And this was after 4 weeks, single injection. You can see that the henna mark has just moved 2 mm. So it is, not a very late picture. And this is after 2 injections. And see, there is all resolution of all the warts have resolved with post-inflammatory hyperpigmentation. That's also resolved spontaneously in 3 to 6 months time. And there is no deformity. The nail plate looks absolutely normal, which is unlikely to happen with radio frequency or laser ablation. So coming to herpetic vitiligo, again more common in pediatric age group, caused by herpes simplex 1. The diagnosis is the clinical examination, where you have closely set vesicular lesion, which gives the like complex sago appearance. And on zinc smear, you can demonstrate multinuclear giant cell. But what is very important is patient will give history of recurrence of these lesions. They occur very frequently because of the trauma is one of the precipitating factor. Fever is one of the precipitating factor. Exposure to extremes of cold. So, but once they happen on fingers, the trauma is the main precipitating factor because the child is writing, playing, and so avoidance of trauma is very important. The individual episode is self-limiting. You don't need to give except topical antibiotic, but recurrence occurs in about 20 to 50% of the patient. And if the recurrences are more than 6 per year, or they're happening every month, then I don't wait for 4 or 6 recurrences. You can give oral acyclovir 10 milligram per kg per dose for about 4 to 6 months in 2 divide doses, and this works really well. I can tell from my personal experience. My both kids had herpetic vitiligo. This is another picture, and it becomes very it gives a premonition that the child will is having a recurrence. The child can tell. Hand, foot, mouth disease. I know it's easy to diagnose because it's a common self-limiting viral disease caused by Coxsackie A16 and enterovirus 71. About 1/3 of the patient will develop nail lesion, which are more prominent in fingernail, and they develop 3 to 12 weeks after the disease has subsided. But parents really get very worried because there is yellow-orange discoloration of the nail plate, Bose line, and onychomatosis. You don't give any treatment. You just wait and watch. So onychomatosis is the separation of the nail plate from the nail bed proximally. And this happens because when there is acute stress of the disease or direct viral infection of the matrix involving the nail matrix, there is complete cessation of the matricial activity. So the nail plate stops forming. Okay. So then there will be onychomatosis, and there is yellowish orange discoloration, the genesis of which is not clear. But you can also see this is onychomatosis and this is Bose line. So you can see that we know that the nail plate grows 1 millimeter per month. So if this distance from the proximal nail fold to the Bose line is 3 millimeter, that means the insult was 3 months ago. So we can ask the parents, when did the disease happen, right? So this helps us in knowing the exact interval, at when the physical stress or some disease happened. So just counseling, and this passes off with the growth of the nail plate distally. Coming to bacterial infections, acute paronychia is very common entity, especially happening secondary to the thumb sucking. So it can be a chronic paronychia or acute. Acute is very painful because of the collection of the pus in an area where there is no scope of collection, means there is no place to get the pus collected. So it becomes really painful. And there will be history of trauma to the thumb or finger sucking. And you can see sometimes there is abscess formation, fluctuant abscess, or just collection of pus. And how do we manage? If there is the abscess is not fluctuant, you can give broad spectrum antibiotic. And if there is fluctuant abscess, it need to be drained. What I prefer is just poke without anesthesia, just poke 18 gauge needle or 20 gauge needle, and the pus will immediately come out, and the pain will subside immediately. Instant pain relief is there. Toenail paronychia is relatively uncommon, but may occur because of the trauma of the tight shoes or injury during the sports. Fungal infection is mainly, if we go about candida, it can be part of manifestation of the chronic mucocutaneous candidiasis, and the other components are oral thrush, napkin dermatitis, but paronychia and candidal onychomycosis. Now, this was a child brought to me by a very senior police officer, and this was an adopted child and had candidal onychomycosis leading to complete nail dystrophy of all the nails. That otherwise the child appear healthy. And when I looked, like, there was no oral thrush, There was no history of napkin dermatitis, and this child had pulmonary histiocytoma. And he was under treatment. And then as a part of CMC, it can be associated with STAT1 gene mutation, which is a functional mutation, or because of the malignancy or immunosuppressive or certain immunosuppressive drugs. So fluconazole is the treatment of choice in a dose of 3.3 to 5 milligram per kg once or twice a week till the lesion subside. Even for CMC, intermittent fluconazole therapy may be required, and there can be involvement of the scalp, external auditory meatus, thrush in the vagina, oral thrush, axilla, groins. So that's a common manifestation. But nails are practically involved in all cases of chronic mucocutaneous candidiasis. Dermatophytic infection, or the infection by the dermatophytes, trichophyton, and the epidermophyton, is relatively uncommon as compared to adult population, but it's not unheard of, and relatively uncommon. So this is a complete total nail dystrophy in a 5-year-old girl child. You do KOH examination in 20% and see under the microscope, you'll see branched separate hyphae. The culture grew Trichophyton rubrum. I treated this girl with the terbinafine 125 milligram per day, because terbinafine is given according to the weight. So 40 kg baby child or an adult, 250 milligram per day. If the child is between 20 to 40 kg, then you give 125. Less than 20, beyond 5 years of age, it's 62.5. That means 1/4 of the dose. And this was the result after 6 months. So there can be complete, and children respond better than the adults I've seen, right? So this is the treatment of onychomycosis. If there is only distal part is involved, you may not give systemic antibiotics. So distal 1/3 you can do with amrolfin nail lacquer or cyclopyrox nail lacquer. These are specialized formulation for the transfungal drug delivery system, or the TUDs, right? For the systemic antifungal, you can give fluconazole, terbinafine. I prefer terbinafine, is much better for dermatophytes than fluconazole. And to diagnose, sometimes if you do not have a microscope or don't intend, but if you have a dermatoscope, then with the naked eye it may not be visible, but on dermatoscope you can see these proximal spikes or jagged margins of onychomycosis. Now, nails in skin disease can occur. Either the nail disease can be isolated nail disease, or it can occur with skin lesion, and most commonly it occurs with trachonicia, lichen nitidus, lichen planus, and psoriasis. Trachonicia is commonest in children, and it was previously known as 20 nail dystrophy of the childhood, but no more this terminology is used, because 20 nails may not be involved, and the disease is commonly seen in adults also. So this has been discarded, the term, but they're also known as sandpapered nails or sandblasted nails or rough nails, because of their appearance as if they have been, sandpapered. So this is there are two types of trachonicia, opaque trachonicia and shiny trachonicia. So this is a very, very classical manifestation of opaque trachonicia, involving almost all 20 nails, 10 fingernails and 10 toenails. Parents were really very worried. And so they can be idiopathic, means there is no underlying etiology. Some eczematous pathology is known to be responsible, but they can occur secondary to alopecia areata, or lichen planus, psoriasis, atopic dermatitis, and ichthyosis. And this is shiny trachonicia. You can see they are very fine pitting, but their nails are very rough, right? And this was in association with alopecia areata. So if they are with this thing, they generally the prognosis does not vary whether it is associated with the skin disease, but depending on the nail manifestation, you have to look for other possible associations. So nail gives us a clue that, okay, this child might have concomitant past history or may develop in future alopecia, lichen planus, or psoriasis. So treat or not to treat, this is the question. It's a benign, non-scarring disorder that resolves spontaneously. It runs a shorter disease course in children, and we need to look at all the skin examination has to be done to look for other associations. And I advise always the no treatment policy or masterly inactivity should be followed in pediatric age group, because lichen planus is a potentially scarring disorder. But in children, even if it is there and manifesting as trachonicia, it is always non-scarring. So counseling and reassurance is the simplistic treatment. I tell them to, use, I'll give some name of the emollient. Okay, use this particular emollient 3 to 5 times a day. It generally helps. And I give oral biotin 2.5 to 5 milligram daily just to buy time, and it works in majority of the cases. So this is the same child which I had shown you, and this was after 8 months. Like, it was pretty good. Like, it was not as bad. It started resolving, and in less than a year time, 50% resolution had already happened. Sometime nail dystrophy will occur in association with the other nail disorders like lichen planus or lichen nitidus. As you can see, the child has lichen nitidus, which is a common entity. But now this is a 10-year or 12-year-old boy, and is very, aware of his appearance, because they go to school and there is a peer pressure for the treatment. So he was really very disturbed and wanted treatment. So I gave, it's not a common thing to happen, but since he wanted treatment, and there was a localized disease, so I gave intramatricial injection of triamcinolone acetonide 5 milligram per ml at monthly interval. All these injections are slightly painful, but then, if the child demands, and this was after 2 months, and that, at least the child is happy and, can move around with his peer without bullying. And this is slight post steroid injection hypo to depigmentation, which resolved spontaneously. So these children should be referred for the injection therapy. Lichen planus of the nail is uncommon in children, and they present with thinning longitudinal ridging, trachonicia, as I told you, nail dystrophy. Pterygium can form, which is permanent dystrophy. It's a medical emergency. It's a emergency, the nail lichen planus. Whenever you suspect, please refer the child to a dermatologist. They may respond to high potency topical corticosteroid. We also give systemic steroid. We can give immunosuppressive methotrexate, hydroxychloroquine, acitretin. But this is a medical emergency, and patient need to be treated. At the first encounter, a decision has to be made, because it's a potentially scarring disease. So, like in this child, I can help him. There is thinning of nail plate and nail dystrophy. But this child, where the, pterygium has already set in, nobody can help. Nobody can help. And the nail will go forever. And they become very important, when they grow up. They have some corporate positions, or they want to mingle with people. Handshake is very important. So because nails are visible, we may not, at this age, we may not be that thinking that they are not important, but when they grow up, they become really important. So this was a child, just 4-year-old, from a very affluent background. And see the nails. So I gave him intramuscular triamcinolone acetonide, and this was the treatment. And then you can give steroid sparing agent like tacrolimus, but I will say refer, because we do repeat dermoscopic examination on every visit to see how the child is responding, whether the pterygium is setting in, or not. Methotrexate is again a very good option because we consider it potential very, very safe drug in pediatric age group with little consequences in later life. And we are comfortable because we use them for many, use methotrexate for many indications like psoriasis. So nail psoriasis, the involvement in pediatric age group is rare. Nail pitting is the commonest finding, as you can see in this child. The pits are irregular and deep, but they can also manifest as trachonicia, topical corticosteroid or vitamin D analog like calcipotriene with or without steroid can be given. And if one or two nail are involved and the nail dystrophy is there, complete nail plate destruction is there, I prefer intramatricial triamcinolone acetonide. It's a very specialized treatment and comes, very few dermatologists are doing it. Very few all over India, all over world, very few. So this was a girl child. I was under really, under great pressure to treat this girl child because she was a VVIP. And instead of, so I gave intralesional hyponequial injections. The disease is only distally. And I gave vitamin D analog under occlusion. And this was the result after 2 injections and vitamin D under occlusion. So, but again, you think it is treated, but on icoscopy, when I see, I still need to treat it further. So these patients need to be referred. There is another entity, parakeratosis pustulosa, which is exclusively seen in girl child less than 5 years of age, and people think that it's a manifestation of nail psoriasis, and this is the classical picture. So you see there is an involvement of 1 or 2 digits, usually the big toe or the second or third fingernails, and there is erosion, crusting, and it's a very discomforting condition for the child. And on a nicoscopy, there are characteristic finding, like you can see these dilated capillaries are there, erythema is there, and psoriasiform etiology is there. Now we don't do biopsy for these because we can confirm the diagnosis on dermatoscopy. So please refer these children because we have treatment for them. Coming to nail tumor, the nail tumor are relatively uncommon, but this is a tumor, infantile digital fibromatosis or raised tumor, which is only seen in pediatric age group. In first year of life, it appears as a smooth pinkish nodule overlying the distal phalanx of the fingers and toe. It lacks propensity to metastasize, but it develops very rapidly. Like at birth, it was not there. This was a 7-month-old child, and but in 7 months it began so huge. So it tend to resolve spontaneously, but how much time it will take and how much parents have patience, that's the key. You can do watchful expectancy, or intralesional steroid can be given, or surgical excision. Actually, I excised this on the request of the parents because they had lost their previous child due to some disorder of skin. They were not carrying the card, but they wanted it to get removed. And this was after 1 year. There is nail plate, so I did not destroy the matrix. So refer. And Conan's tumor are important. It's very important to identify this disease because sometimes a patient has not developed other components of tuberous sclerosis, and they have just these little tumors, periangle fibromas. You can see these garlic clove like picture. They are called garlic clove tumor because of their resemblance to the garlic cloves here. So they're all children, and they may throw epileptic fit, and then that this is can be a part of the complex tuberous sclerosis complex. So it's important to identify and look for other features. Subungual exostosis, I myself have seen about 5 or 6 cases so far. These are the benign bone tumor of the distal phalanx, and they appear as subungual form nodule, the bony consistency, and cause uplifting of the nail plate and pain. Trauma is a precipitating factor. X-ray is diagnostic because in X-ray you can see that the digital fillings, there is an extension and surgical removal is the treatment of choice. This is from the ventral aspect. And this is the extension. You can see. So this confirms the diagnosis. I usually don't excise. I send it for to the ortho people for excision. Now, very important thing, and almost every month I get a child who has developed melanonychia or the nail plate pigmentation. I don't know, with the social media and with the Google uncle around, everyone is so scared of melanoma. We are fortunate that we, being the brown skin, we hardly get melanoma. And even melanoma as compared to Western population, even in Western population, white population, it is not common in pediatric age group. Up to 18, they don't even biopsy the lesion. And now again, as I say, that onychoscopy is an important tool. So melanonychia is nail plate pigmentation. It can be gray, black, brown, black. Sorry for the spelling error. Its prevalence varies. It's more common in adults and in darker skin individuals. MEVI and lentigo are the common causes in children. MEVI are the most common causes, and they may develop at 2 to 4 years of age and present as melanonychia. And they present with Hutchinson sign, which is pseudo Hutchinson sign, and melanoma is extremely rare. So there can be three types of nail pigmentation. It can be diffuse, which can be because of the racial or constitutional color in, say, type 5 skin. If more than one nail are involved, it can be because of the drugs, because of the HIV infection. And drugs like cyclophosphamide or chloroquine or tetracycline can also lead to pigmentation, or vitamin B12 deficiency. Longitudinal melanonychia is majority of the cases are nevus. Remaining, if 80% nevus, 20% lentiginous, and melanoma, I will not say even 1%. Transverse melanonychia is majority due to drugs. So first you have to classify whether it is diffuse and involving single nail or multiple nail. So how to approach? Now the approach is step one, whether it is exogenous or endogenous. So this is henna pigmentation. So exogenous pigmentation will have a margin parallel to the proximal nail fold, right? So this is convex proximally, this is convex proximally. So this is external. Second part is we have to ensure where the pigment is melanin or not. So this child had blackish pigmentation, but on onychoscopy, you can see it's reddish with globules. So this is subungual hematoma, and it has already moved from the proximal edge of the nail plate. Okay. The third is pattern of pigmentation and how many nails are involved, whether it is diffuse, transverse or longitudinal, or whether single nail is involved or multiple nail is involved. The rule of ABCDF do not apply on the children, right? When we say that Hutchinson sign is positive, it's strongly indicative of melanoma. No. So this is like a patient on immunosuppressive therapy, diffuse pigmentation in all the nails, and it is transverse, as you can see. Transverse is exclusively because of the drugs. This is like really scary, right? And you can see, and positive Hutchinson sign because there is proximal skin fold is also involved, but this is nevus. Okay, and this is single, and this was because of the trauma. Now, these are the patients who actually parents have more concern. And this patient comes from Srinagar, and you can see there is again spilling of the pigmentation in the surrounding skin, which in adult is a short evidence of melanoma, but in children it is not. One should not feel scared. And so what is required in a child? Clinical examination, photography, and dermoscopy, and they should be documented in every visit. So I usually call them at 6 monthly visit. The biopsy is required of the nail matrix only when the parents are too anxious, but I think with good counseling skill and seeing you being comfortable with the pigmentation, they usually don't ask. Band rapidly enlarges or show variegated pigmentation. So I can show that this is a pigmentation. This is not a variegated. This is the parallelism is maintained. The lines are parallel to each other, and they are parallel to each other, but they are not like in the same band. There is no variegation of pigmentation. Like this is light brown, so this is light brown across the whole length. If this would have been dark brown here or black here or blotchy pigmentation, I would have gone for the biopsy. So parallelism maintained is very, very important. So you look for whether the parallelism is maintained, whether there is variegation in the pigmentation in the same band, and third, whether there is any bleed. So bleeding in a pigmented lesion is again a bad marker and may represent malignant transformation. So you need to biopsy only when it rapidly enlarges, show variegated pigmentation, or causes destruction of the nail plate and bleeding. All malignant lesion will cause destruction of the nail plate. All benign lesion will cause deformation of the nail plate. This is a very, very important carry home message. Though histopathology, of course, remains the diagnostic gold standard, but we are very happy with the dermoscopy follow-up. So if you have this kind of a patient and you want to refer, please refer. Trauma to the nail unit, like habitic deformity, onychophasia, hangnail, ectopic nail. This is habitic deformity result because of the external trauma to the nail matrix. So the child keeps fiddling with the nail plate, keep pushing the proximal nail fold backward. Okay, it's a more of a habit with no prior anxiety, and treatment is like topical emollients you can give, counsel the child, make them aware that this is not good, and you can tell them repeatedly not to do whenever you find or observe them doing it, or you can bandage it, tape it. You can use cyanoacrylate glue also, because this proximal nail fold is, there is no cuticle in these patients. So as it is, they are more likely to get. And this child was fiddling even with the toenails, which is very rare, and I published it actually. So, he was doing it. I asked him that, how do you do it? And he told me how he's doing, fiddling with the nail plate, nail matrix. So onychophagia, again, very common, and this can lead to hangnails, which are very painful because these are the deep cuts, and it causes the erosion, linear erosion. So these are the child finds it a way to lessen the anxiety or the stress, or it becomes a habit rather than a way to let out some anger or frustration. Onychotillomania or nail picking. Now this has to be not just a habit. It's definitely a manifestation of, considered a manifestation of OCD, because this can lead to self-mutilation of the nail and the surrounding skin. So they keep picking the nail plate and the skin, surrounding skin also. I frequently, and they will vehemently deny that they do not manipulate. I use fluoxetine in children aged 8 years, specifically when there is anxiety disorder and the parents are also equally anxious. Ectopic nail or the onychoheterotopia is a rare condition. It's usually post-traumatic, where the germinal matrix is implanted at the site of injury. And so, like this child had his hand in the door, so he has two nails to take care of. And either you remove the entire germinal matrix, which is implanted ectopic matrix, surgically, or you can counsel the patient that this is just part of growing up, and this is regular trimming of the nail plate is required. Another patient with the same kind of injury and has got nail matrix implantation in the nail bed. So I took out the nail, and there you see that this is not the site of the nail matrix, but this is growing up from there. So refer punctate strate leukonychia, you must be seeing them. These are because of the trauma to the nail matrix, self-limiting, avoidance of trauma, emollient and multivitamin can be given, but no calcium. They are not due to calcium deficiency. Nutritional deficiency, like onychomatosis can occur because of the protein energy malnutrition, Bose-Line because of the protein energy malnutrition, koilonychia, iron deficiency, and melanonychia, vitamin B12 deficiency. So this is koilonychia. You can put a drop of water, it stays there. Iron deficiency anemia, Bose-Line and onychomatosis because of, again, the PEM or some stressful episode. This is vitamin B12 deficiency. Patient has involvement, pigmentation of the digit also, and this is completely reversible with the injections or with tablets 8 to 12 weeks. Nails and calcium. Actually, I have put this slide specifically because calcium is prescribed. I've seen a lot of prescription from the pediatrician. Calcium content of the nail plate is 0.03% against the 20 to 25% in bone. Sorry, this is mistake. 20 to 25%. And this study from New England Journal of Medicine was a randomized placebo-controlled trial of calcium supplementation of 1 gram elemental calcium to all the post-menopausal osteoporotic females. And there was no change after 1 year in the either on the brittleness or the surface texture. So calcium is not to be given, at least for nail disorder. The carry home message is that the nail is a fascinating world of science to be explored by the dermatologist and the pediatricians and all the physicians alike. Nail lesions may be a source of great concern for the parents and older children. It's important to know what are the physiological nail changes in neonate and infants and identify other nail changes early. Most of the nail conditions are treatable and the process is extremely rewarding. And it's important to know when to refer to a dermatologist. Thank you for your kind patience. And this is a nail disorder book we have published. So in case you want more information.
Thank you, ma'am, for a wonderful presentation. It was really enlightening. And I know nails are a window to many systemic disorders. We must examine nails in all children because there are many systemic conditions which can be diagnosed from the nails also. Even in infective endocarditis, you can see bleeding spots in the nail.
And all can be, yes.
Yes. So we must examine the nails even if child is visiting for any other problem.
Yeah.
Dr. Amit, are there any questions? Dr. Bhandari, sir, would you like to say something?
First, let him take the question, I think.
Yes, sir. Ma'am, though it's not related, but treatment for nail biting, I think this is more of a stress disorder in children.
Yeah, no, biting. Actually, the leukonychia on the nail, as I told you, it is because children, they keep fiddling with the nail fold, and underlying is the nail matrix. So what happens that when there is complete keratinization, these white points on the nail, as I showed you in the picture, they represent parakeratotic keratinocytes, means incomplete keratinization is there. And this is there because of the trauma to the external matrix. So calcium will not help, emollients will help, and telling children, counseling them not to fiddle with the nail matrix or the proximal nail fold, the proximal nail fold. That is the key. They keep pushing it backward. So sometimes it manifests as habitic deformity if it is gone to the another extent. But if there is an injury, then it manifest as leukonychia, and it can be a manifestation of nail psoriasis also.
And many times ingrown nails also, when the nail is going into the folds.
Pardon?
Ingrown nails.
Okay, ingrown toenails are actually uncommon in pediatric age group, if I take pediatric age group 15 to 18, but most of the ingrown toenails are very painful, and we do matrixectomy with the partial nail avulsion. It's a surgical process, very easy to do OPD procedure, but grade 1 can be tackled with taping, but grade 2, 3, when there is excessive granulation tissue formation, usually are treated with surgical intervention, and we call it partial nail plate avulsion with chemical matrixectomy. So the nail plate gets narrower because we have removed or chemically cauterized the nail plate, nail matrix.
Lines on
Pardon?
Yes, there are a series of questions. If you can quickly go through them.
Yeah, please. But I don't see.
Ajay, can you see?
Yes. Vertical lines on the nails. What can be the reason?
Just a
Vertical
minute.
line.
Can you please some good emollients? Any emollient which is good for skin is good for nail. White Vaseline I prefer. That's a very good because emollient, because Vaseline is ointment base and it stays there. It gives a occlusive dressing. But what is very important is if they can see me. Can they see
Yes.
me?
Yes,
On the
ma'am.
screen?
Yes, ma'am.
You always tell from proximal to distal.
Okay.
Okay, so 4 to 5 times a day, nail emollients are very good. Every person, because we wash our hands so many times in our own practice, and COVID has taught us how to use frequently the sanitizer, which is it deprives us of all the lipids or the moisture of the on the nail. So it is very good. I find Vaseline, white Vaseline, plain emollient is the best emollient. You can use white soft paraffin also. It comes with different names, like any moisturizing cream, Nivea cream, any, like whatever you have. Coconut oil is also fantastic. I prefer, because I cater to the poorest of poor. My vote is for white Vaseline and coconut oil, but you have to use it in this direction rather than massaging.
So differentiate between hermetic vitilo and bacterial paronychia.
Yeah, it's very, very herpetic vitilo and paronychia, right?
Yes, ma'am.
Okay, so it's very easy. Paronychia will have only the involvement of the nail and it will show pus. Vitilo will not show any pus unless and until it has, the vesicles have ruptured to form erosions. And paronychia is extremely painful, like collection of pus in an area where you don't have a space. It's extremely painful, and it is not recur. And there is a previous history of, trauma. Like there is some hangnail you can see, or there is some, the finger sucking habit, or onychophagia, you can see that, trimmed nail. But herpetic vitilo is mostly seen on the pulp. Paronychia is seen along the nail fold. And in herpetic vitilo will not respond to antibiotic. Usually the history of recurrence is there. First time herpetic vitilo may be painful, but you will see the typical you see on herpes labialis, you will see these lesions even in vitilo also.
Please explain how to approach Bose lines.
Achha, Bose line are because of the transient stress. So no treatment. Like I did not put picture.
Masterly inactivity.
Yeah, masterly inactivity. I'll just give you an example. My colleague's daughter started periods and she gets stressed a lot. So she, on all fingers, she had, 1 millimeter ke distance pe she had Bose line. And that corresponds with her menstrual cycle. She did not allow me to take pictures. And consent, I think, is very important.
Yes,
so you can, you can show your wisdom to the parents that, okay, this has happened 2 months ago, your child had fever or some surgical intervention or some trauma. So, and they tend to move out with the growth of the nail plate distally. So no. And whenever you do masterly inactivity in a pediatric age group, I think it's very difficult to convince parents. I don't know. That's my this thing, because I don't cater to only pediatric population, but they are difficult to counsel. So I always give, of course, emollient, some fancy one which they need to buy. and a multivitamin can be given, which you think is the best, will have zinc or multivitamins rather than biotin, I prefer.
I think we can ask them to visit again after 3 months or so.
Yes, that is very, very important actually, that you want to
Yeah.
see. So you consider that slight important.
How to treat hangnails?
Hangnails, like, it's very difficult because it's usually a habit of again fiddling with the nail, and so emollient again are very helpful because they happen secondary to the dry skin, secondary to the onychophagia, eating nails. So, and sometime what I do, like, this is a trick and this has been published in JAD, which is like impact factor of 16. So what I do in a child, if they're very painful, so take that glue, we have this glue, cyanoacrylate glue, and I just put it and tape it with the hangnail. So it's very simple.
Does this dermoscope has UV light or is
No, it's a polarized and non-polarized light, and it's magnifies. So it's
okay.
yeah, it's a inbuilt light source is there. It's expensive though, but
Dr.
it's
Amit,
very helpful for us.
are there any other questions that need to be answered?
Somebody had
Most of the
written.
questions are related to the emollients only, any good emollient. Can you name any good or good
Yeah,
emollient?
so I think Vaseline or any fancy one, you can give Lubriderm. So if patient want very expensive one, you can have, these days we have CeraVe also in India. So CeraVe moisturizing cream is there if you want to spend $1,000. If you want to spend just 50, coconut oil is there. If you want to spend 100, white soft paraffin and white petroleum jelly is there.
Thank you. Thank you. So most of the
Dr.
questions.
Ramesh Bajania from Central IAP is here with us for his comments, please.
Hello.
I
Am I
read
audible?
somewhere somebody has written about the rheumatic disorder. That means connective tissue disorders. I did not include it because they are uncommon, and nail fold capillaroscopy is done, but the pediatric population has less of rheumatology. We do not encounter too much of rheumatology patients, but nail fold capillaroscopy is a very good way to know the activity, disease activity.
Dr. Amit, are there any more questions?
Yes, Ramesh ji, please.
Yes, in fact, it was I was spellbound with the presentation from Dr. Archana Singal, because during our residency we had